Alana has just gone over the social determinants of health in rural, which, as you can tell, were a little bit less optimistic than we might like. There are going to be additional sad stories that are going to follow my talk. We're going to talk about mortality in rural areas. We're going to talk about race-based health disparities. A lot of speakers are inevitably going to have to talk about COVID and what it's having as an impact on rural. But I am going to propose sort of a underlying mechanism that I want you to sort of think about as you listen to all these statistics. I'm interested in the 5 whys. Why do problems occur? And in a nutshell, my proposal is that they're never going to fix rural health and rural health issues while we are working in a framework that, however unintentionally, it just sort of evolved, but the framework systematically discriminates against rural populations. I'm going to call it structural urbanism. I'm going to explain what I mean to you by structural urbanism and why I think it has the effects it has on health outcomes in rural. And then I'm going to try to convince you, like, not only is this problem real, but that there are steps that we can take to address it if we wish to, all in 15 minutes. So I'm going to talk even faster than usual. Okay, there will be a quiz. For 15 seconds, I want you to look at this picture and make notes of the things that you see in it. Okay. Time's up. We're moving on. Now I'm going to talk about what is structural urbanism. And I think if you look across the US, we have a strong bias towards large population centers that emerges from a focus on individuals rather than infrastructure. Let me say that again. When we think about health, the buzzwords are Medicare for all, or we've got to expand Medicaid. We think about individuals rather than what is the infrastructure that we need, what are the populations we have to serve. And I will note that as far as I know, because I could be wrong, the last major investment in health services infrastructure, not persons, infrastructure, was the Hill-Burton program, which was in effect from 1946 to 1997 and funded the construction of hospitals and other healthcare facilities based on community need. Since that time, I would suggest we've really focused almost exclusively on extending the ability of individuals to pay for care. We have Medicare, we have Medicaid, both in 1965. We have the Affordable Care Act in 2010 with Medicaid expansion taking effect in 2014. All of those focus on providing individuals with the money to buy something, as if they were going to go to the store and buy mascara. Sorry, that was a little disrespectful. But whether we're talking about fee-for-service or capitation, we're still talking about giving people one at a time, the individuals, the ability to acquire health care. The problem is that focus on counting people has a certain number of downfalls, both in healthcare services and in public health. And the basic element on why the focus on individuals fails is scale. You can't run a program without a minimum number of funded participants. In public health, we focus on national goals. This notion that you have to have a minimum number of participants to play means that rural gets left out. Estimates are that it takes between 1,900 and 2,500 person patient panel to run a physician's office. And that's in a good area with private pay. So if you've only got a few people, you end up with very few practitioners. And in metro counties in the US, there are an average of 53 physicians for every person. For every 100,000 people. That would be a lot of physicianing. 53 primary care physicians for every 100,000 people. In rural counties, not only are there fewer physicians, there are only 39 per 100,000. It drops. And I'm going to say, by the way, that this problem is not unique to healthcare. It also affects education. It affects a lot of things. What happens when you have to have people buying healthcare in little bits, a la carte, is that you don't get it where people might actually need it. Recently, the Kaiser Family Foundation and Kaiser Health News developed this nice graphic that shows ICU beds. That's what they were concerned about. Would we have the ICU beds or transformable beds to handle the COVID epidemic. But I'm going to call your attention to all these little gray areas. These are areas that don't have hospitals at all. Whoa. So why don't we? And okay, so you're going to say, wait a minute. These are a lot of little counties. They don't need their own hospital. But let's look at a very small service. And I'm going to talk about patient education, which is under Medicare and Medicaid a billable service. Diabetes is a classic example of a disease for which patients take care of themselves. And it's not intuitively obvious. It's not taking a pill. It's checking your glucose. It's monitoring your insulin. There's a lot of stuff you have to do to manage diabetes. And diabetes is highly prevalent among US adults. About 9% of urban and 9.9% of rural adults have diabetes and therefore need to be able to take care of it. But even though people take care of this disease by themselves, you'll notice that there's still a lot going on. In total and in every age, both working age adults and older adults across every race, ethnicity, rural residents are more likely to die each year than are urban residents. The distinction in the youngest age group, rural is about 46% higher than urban. It's about 24% higher in this older age group. So why are the rural people dying? Now, there are compositional factors influencing the rural population. Lower education for the persons in the working age group, lower rates of health insurance. But there are also, I would suggest, contextual factors caused by the fact that you have to build infrastructure one paying person at a time. It's not just that rural populations are somehow deficient. It's that, I'm hoping this all shows on your screens because it doesn't quite on mine. Yeah, that 62% of rural counties do not, repeat that, 62% of rural counties do not have a diabetes management education program within the communities within the county. And this is fairly simple. If you get certified as either a certified diabetes educator, physicians can be trained to do it. But there are vast swathes of the country where there is probably a lot of diabetes. I know it's one of our favorite diseases in South Carolina, along with hypertension, that people would have to drive a great distance to learn how to effectively take care of their population, how to effectively take care of their diabetes. That is not the sole cause for increased mortality, but at the margin, the lack of services matters. So the takeaway here is that funding mechanisms that reimburse healthcare services provided to an individual will never serve small populations fairly. And yes, this applies to everything, and I'll go into it a little bit later with regard to all of the tweaks that we have. Realistically, MedPAC feels that home health care providers, for example, are less efficient if they serve rural areas because they have more windscreen time. There's a whole bunch of characteristics of rural populations that mean it won't work unless we think about it differently. And by the way, public health has the same problem. If you're running a big agency like CDC, you are charged with the health of the nation, and you set goals for the nation in terms of Healthy People 2020. And for example, an article presented in JAMA Pediatrics in 2018 was full, if you will, of delight. Basically, by 2017, the national targets had already been met for most of the categories of child, in terms of we had already reduced the death rates by the amount that we desired, except for the 10 to 14 age group. That's the only one where we were not hitting our goals. So, hey, we're in great shape. As my physical therapist would say, not so fast, Skippy. Let's look down a little bit at what we're doing for rural in that same area. You'll notice that rural children in every category are in fact have higher death rates than urban children and are not meeting those national goals. So if you do not specifically drill down and just focus on big places to create your national success, you will have not making any improvements in rural. when we move the needle, when we count people one at a time, we neglect rural surveillance. I'll just toss this. Well, excuse me, I should not play with this arrow. When we neglect rural surveillance, for example, in Health United States, which is a document that comes out every year, in 2017, it had 144 distinct tables, but only 19% of them addressed issues among rural populations. I'll also point out another thing that happens. When you look at absolute numbers rather than severity, you restrict rural opportunities. Everyone who is listening to this, who has been active in public health for the past 5 years, probably remembers the drug-pushed HIV epidemic in Scott County, Indiana. Scott County, Indiana. They only had, basically, at present, they have 150 persons with HIV/AIDS living in Scott County. But that is a population-based statistic of 630 per 100,000, which is well above the national average in 2016 of 421. Let me slow down and say that again. In a small county, you can have a horrible rate of disease, but if you only count the numbers, you won't see that rate. And this can really, as I say, restrict opportunities. One of a problem that we got quite irate about in South Carolina was when community transformation grants were structured so that you had to have a minimum population of 500,000. That's going for the big needle moving, but it rules out rural definitionally. The only way we could even bid was to try and come up with a program that served the entire state. Okay. COVID is just going to make everything that we have just talked about worse. When we are having person-based payments, those declines are hitting small facilities hardest, with declining physician office visits, even in community health centers, with rural hospitals furloughing staffs. And as long as we're just going to pay one person to visit one doctor, and you, there's no clear way of rural recovery. There's a Bruce Springsteen song where he sings, "These jobs are leaving, son, and they ain't coming back." When these hospitals close, when these physician offices close, we have no mechanism to get them back. COVID could decimate rural America even more than it has in terms of the damage it will do to infrastructure unless we change the way we think about rural and the way we think about funding and rural healthcare. And tweaks at the margins are never going to work. Okay, remember this picture? I was going to have this slide in, but they wouldn't let me because they said that might screw things up. Wow, sugar frits. Sorry. I need a pointer, and there's no pointer in electronics. But see those little red arrows? If for those of you who are very clever, you will see a road and you will see electric lines. What are they doing there? Loving County, Texas has 169 people. They cannot afford to pave asphalt. They cannot afford to put up telephone poles. But there is a decision made at the state and national level that roads and electric are good things and that you provide them, even though the individuals, communities cannot support them. We define these things as infrastructure. Does that make sense? These are things that in no way Loving County, Texas could afford, but like Loving County, Texas has. I think that we have to stop thinking about healthcare as a discretionary purchase made by individuals and start thinking of it as infrastructure within a community. Healthcare, what does this community need so that people can live there, can live their most healthy lives? It can have industry come to the community. For those of you from one of my earlier studies of hospital closures where we called somebody in every county where a place closed, one of the things that happens when a hospital leaves a community, for example, is that industry does not want to come anymore because their workman's comp is linked to how fast they can get care for an emergency, et cetera, et cetera. But if we think about healthcare as infrastructure, we can start thinking about it, funding it as a utility. a regulated, either through taxation or as a regulated utility with fees that maintain services for populations that need. So you change your thinking from, well, this hospital's not viable, Medicare is never going to save it, to, we're going to make sure that we reimburse this institution sufficiently to keep it in the community. I don't want to oversimplify. I know that this is not easy. Like, what are the geographic levels at which we define the level of support? Is it the state? Is it a Tennessee Valley approach where we look through the whole Mississippi Delta? Is it combinations of this? I'll also note that even in countries that have a central health service, like Great Britain, the determining how much is needed in rural and how much is needed in urban is not an uncontentious process. However, if we don't start thinking about change, it's going to get worse. I do not see good things coming in the next year. We have an epidemic that's out of control. We are going to lose rural health infrastructure, but we need rural. The United States of America is not Manhattan. We cannot be internationally competitive without a strong rural base for extractive and small manufacturing industries. Rural healthcare is dying, and all of the research has shown that the communities that lose a hospital, for example, are those that most need it. We need to focus on communities and their infrastructure as a path forward. And I will point out, although this not specifically paying for this research, that our center has over the years received considerable support from the Federal Office of Rural Health Policy and from Children's Trust of South Carolina. Thank you.